Hi everyone, and welcome to our module on intracranial bleeding. Before we talk about intracranial bleeding, let's talk about raised intracranial pressure, or ICP, in general. There are many conditions that can do this, and the symptoms of these conditions overlap. So mass lesions like tumors can raise the pressure in the skull, so can cerebral edema, so can hydrocephalus, which I talk about in detail in the module on ventricles and sinuses. If you have obstruction of the venous outflow from the brain, this is usually a dural sinus thrombosis, you can get high pressure in the skull. And then finally, there's a condition called idiopathic intracranial hypertension, or pseudotumor cerebri, which raises the pressure inside the skull. There are some general symptoms that all these conditions cause that you should know about. So headache is one of them. There are pain fibers of cranial nerve 5 in the dura, and they get irritated and give patients headache. Patients with high intracranial pressure can have depressed consciousness. They can be somnolent and lethargic, and this is because of pressure on the midbrain reticular formation. And finally, vomiting is common in patients who have high pressure in the skull. A very important sign of increased intracranial pressure is papilledema. This is swelling of the optic disc from high ICP. It's also seen in patients with severe hypertension. So for example, someone who acutely presents to an ER with a very high systolic pressure over 200 may have this. It's usually bilateral, and what you see are blurred margins of the optic disc on fundoscopy. This is an example up here. So down at the bottom is a patient with a normal sharp optic disc on fundoscopy, and up at the top the optic disc is blurred, and that is from papilledema. Patients with very high intracranial pressure can have what's known as Cushing's triad, and this is hypertension, bradycardia, and irregular respiration. And the way I always remember this is from the stories I read about Abraham Lincoln's assassination. So he was shot in the back of the head while watching a play at Ford's Theater, and there was a physician in the house who came over and found the president bradycardic with irregular breathing, and he pulled the blood clot out of the back of his skull and relieved the pressure, and his pulse picked up and his breathing went back to normal, although he died a few hours later. And so for better or worse, that's how I always remember Cushing's triad, and use that if you like it. Patients with severely increased intracranial pressure will do what's called posturing. So this is usually an unconscious patient, and they will develop one of the two poses on the screen here. The top one is called decorticate posturing. That's where the arms are flexed, and this is more common when there's damage high up in the brain, like in the cerebral hemisphere. Some people call this the mummy pose because it looks like a mummy in an Egyptian tomb. The bottom position is called decerebrate posturing. That's where the arms are extended, and this is more common in brainstem damage. It's believed that the red nucleus is the key here. If the lesion is above the red nucleus has a lot of flexors involved in its system. So if the lesion is above the red nucleus and the red nucleus can still function, you get decorticate posturing with the arms flexed. If the lesion is at or below the level of the red nucleus, like in the brainstem, you get decerebrate posturing. When you work in the emergency rooms, or if you work on an ambulance, you will discuss the Glasgow-Coma scale to describe patients with head trauma. So let's talk about that. It's 3 simple tests of a patient's eye, verbal, and motor function. And based on their response to these tests, they get a score from 3 to 15. So 3 would be a completely comatose, unresponsive patient, and 15 is a normal, awake and alert patient. So the way you do the Glasgow-Coma score is first look at the eyes, and you give them 1 to 4 points depending on whether the eyes do not open or all the way up to open spontaneously and everything in between. You give them 1 to 5 points for verbal, so if they're not making any sound, that would be 1 point, and if they're completely oriented and talking to you, that would be 5. And then you give them 1 to 6 points for their motor function, so no movements would be 1. Decerebrate posturing is 2, decorticate is 3, and then there are other points for these other things down here all the way up to completely following commands. So when you work in the emergency room, you'll hear ambulance drivers calling in for patients they're bringing in with trauma, and they'll say the patient has a GCS of 3 or a GCS of 15, and this is what they're talking about. Herniation is a process where expanding volume inside the skull, like from blood or tumor, forces brain through the weakest points, and it's very serious, and most patients do not survive when they have this occur. So let's talk about where displaced brain can go, and these are the herniation syndromes. So there's basically 4 types of herniation you should know about. The first type is called subfalcine, and that's number 3 over here on this picture. And that's when a portion of the brain called the cingulate gyrus goes under the falx cerebri. We'll talk more about that in a minute. Uncal herniation is when the uncus, which is the medial temporal lobe, goes down into the brainstem, and that's number 1 over here on this picture. Central herniation is number 2 on this picture. That's when the diencephalon herniates downward against the midbrain. And then finally, tonsillar herniation is when the cerebellar tonsils go through a small hole and compress the midbrain. So we'll talk about each of these now. So let's talk about subfalcine herniation first. That's number 3 on the picture on the right, and I've circled it for you. And that's when the cingulate gyrus herniates. So what is the cingulate gyrus? That's the portion of brain tissue that sits right next to the corpus callosum. And you may remember the corpus callosum connects the right and left hemispheres of the brain. And it's also very close to the falx cerebri, which is dura mater that is at the top of the skull. So the cingulate gyrus will herniate and go under the falx cerebri. And what's important to know about this herniation syndrome is that it will drag the anterior cerebral artery, or the ACA, with it. The ACA therefore gets compressed, and you may recall that the ACA supplies the motor neurons that innervate the leg. So you get leg paresis with this herniation syndrome. So if you look over here at the picture on the right side of the screen, if this portion of brain herniates this way, it will be the ACA on this side that gets knocked out. And that means the legs on the opposite side of the body will be affected. Uncal herniation is when the uncus herniates, and the uncus is the medial temporal lobe. It's number 1 on that picture on the right, which I've circled. And it herniates and goes across the tentorium. So the tentorium is the dura mater above the cerebellum, and this compresses the midbrain. So uncal herniation has a few specific signs and symptoms that you should know about. The first one is cranial nerve 3 compression. So that herniating tissue will compress cranial nerve 3 in the midbrain, and this will cause loss of parasympathetic innervation, and you'll get a dilated blown pupil that doesn't constrict to light. So remember, a herniation syndrome is going to usually occur in an unconscious patient, so you're not going to be able to test eye movement and all those things. But if you open their eyelids and you see that the pupil is blown and doesn't react to light, that's a very ominous sign that suggests an uncal herniation. You'll also get collapse of the ipsilateral posterior cerebral artery. So this is the artery that supplies the occipital lobe and supplies your vision. So these patients have cortical blindness. If you're able to test their visual fields, which you often aren't because they're unconscious, you would detect homonymous hemianopsia. And I talk in some of the other modules about the visual field defects in someone with a posterior cerebral artery infarct. Also, you get compression of the cerebral peduncles. So these are areas that carry motor fibers in the brainstem. So you can compress the side with the lesion, and that will give you contralateral paresis because those motor fibers decussate below the medulla. However, there is something called Kernahan's notch, and this is when the opposite side of the brainstem gets compressed. So let's look up at this picture here. If this uncus pushes here so much and it compresses the opposite side of the brainstem, you will get paresis on this side of the body. It's called a false localizing sign because it'll appear that the problem must be on this side of the brain, but it's actually on this side. So that's called Kernahan's notch. And then finally, there's something called direct hemorrhages of the pons and midbrain when you get breakdown of perforating branches of the basilar artery or the draining veins. And this can occur with other herniation syndromes too, but it does occur with uncal herniation. So if you want to recognize this, especially in a board question, look for a dilated pupil. That will always be on the side of the lesion. Look for a visual loss in the patient and hemiparesis or quadriparesis. All these things suggest uncal herniation. A transtentorial herniation is a herniation of brain tissue that crosses the tentorium. The tentorium is the dura mater that separates the lobes of the brain from the cerebellum. So anytime brain tissue crosses this tentorium, it's called a transtentorial herniation. Now, an uncal herniation is one subtype of transtentorial herniation, but you can also have a central transtentorial herniation, as is shown in number 2 on the drawing on the screen here. When you have that type of herniation syndrome, the thalamus, the hypothalamus, and the medial parts of both temporal lobes cross the tentorium cerebelli. This is usually a fatal condition. It leads to somnolence and loss of consciousness. The pupils go through a progression where they are initially small and reactive, and then they become non-reactive. The patient develops posturing, and as I said before, patients usually do not survive transtentorial herniations. And then our last herniation syndrome is called tonsillar herniation. The cerebellar tonsils are the bottom portion of the cerebellum, and in this syndrome they herniate outward and down through the foramen magnum. This is most commonly caused by some type of mass lesion in the posterior fossa, and this is usually a fatal condition. That's because compression of the medulla occurs. This results in depression of the centers for respiratory and cardiac rhythm control. As a result, patients who develop this usually develop cardiorespiratory failure, and it's usually fatal. So everything I've talked to up until now has been about general principles of raised intracranial pressure, but now we're going to talk about specific bleeds. So the 4 types of bleeding in the skull you should know about are epidural hematoma, subdural hematoma, subarachnoid hemorrhage, and hemorrhagic stroke, and we'll go through each of these in the remainder of this module. So just a brief reminder on the meninges. So if you take the skull bone here and you look beneath it, the first layer is called the dura mater, and it's very thick, and that's why it's called dura, like durable. Beneath that are two thinner layers called the arachnoid and the pia mater, and those are thinner. They're often called the leptomeninges. And the dura, arachnoid, and pia together form the meninges of the brain. So let's talk about epidural hematomas. This is when you get rupture of the middle meningeal artery, which is a branch of the maxillary artery. I'll show you a picture of that later. It's almost always traumatic, so usually there's a fracture of the temporal bone, and this leads to an epidural hematoma. The key thing to know is that it has a convex shape on CT, so the dura are attached to the sutures of the skull, so lesions can't cross the suture line. So let's look at this picture over here on the right. If you have a rupture in this area here, the bleeding will spread this way, and it will spread that way. But when it reaches this suture line right here, it can't go any further, and then it bulges out in this convex shape like that. And that's why it has the convex shape on CT, and this differentiates it from subdural hematomas, which we'll talk about in a minute. Epidural hematomas can cause something called midline shift. They can build up so much pressure in the brain that they shift the midline this way, and this is a picture of that. So remember, this is an arterial bleed. It's a high pressure vascular structure, so it's going to quickly fill that space and exert significant pressure on the brain, and that's why epidural hematomas are much deadlier than other bleeds from venous structures like subdural hematomas. Here are some pictures just to remind you of the anatomy of the maxillary artery. So the blood comes from the external carotid here, and then the third upper branch is the middle meningeal artery. It's sort of not that significant when you're looking at it in the anatomy lab, but it's very important for these epidural hematomas. So this is a picture of a patient with a skull fracture, and if you look very closely on the right side of the image, I'm circling right here where there's a tiny crack in the skull. It's subtle and not easy to see, but there shouldn't be a crack there that's not one of the suture lines. And when you see that, you should know that that patient is at risk for rupture of the middle meningeal artery and development of an epidural hematoma. You should know the symptoms of epidural hematoma. So there are general symptoms like headache and drowsiness and loss of consciousness, and I describe these for patients with any type of raised intracranial pressure. One special thing for epidural hematoma is called the lucid interval. So what happens is that the patient gets a severe concussion to the head, and they initially are knocked out by the concussion. Then they come to and they stand up, and people may think, oh great, they look good. But unbeknownst to the patient, they are bleeding into their skull from the middle meningeal artery, so sometime later, 20-30 minutes, they will pass out. And this is why patients who initially regain consciousness after a head injury aren't necessarily out of the woods. If they have bleeding, it may not be apparent till later, and they need a full evaluation. So next we'll talk about subdural hematoma, and these are also traumatic, but these are rupture of the bridging veins, and the bridging veins drain blood into the dural sinuses. Because they're venous structures, the pressure is lower, and therefore the symptoms usually aren't as severe as epidural hematoma. These patients get blood between the dura and the arachnoid space, and it's high yield to know that, and it's usually a slow bleed because these are low pressure structures, so the symptoms won't come on as acutely after the trauma as you would see in epidural hematoma. The key finding on a head CT is a crescent-shaped bleed, so let's look at this picture on the right. Notice that this bleed goes like this and forms sort of a long crescent. It doesn't get that nice convex shape we saw with epidural hematoma. So that's the difference between the two on head CT. These bleeds can cross the suture line, which differentiates them from epidural hematomas. They can only spread so far, though they do get limited by reflections of the dura, so the falx cerebri, the tentorium, and the falx cerebelli all are places they can't cross. So where you're most commonly going to see subdural hematomas are in elderly people who fall. Old age is a risk factor for this condition. So is being an alcoholic, and so is taking blood thinners like warfarin or antiplatelet agents. The reason old age is a risk factor is because there's brain atrophy as you get older, and this increases the space those bridging veins have to cross. It makes them more vulnerable to rupture. And a classic history, especially for a board question, is someone who has a head injury but doesn't get evaluated and then a few weeks later develops confusion and headaches. That person may have a subdural hematoma. This also is a classic injury in babies who have the shaken baby syndrome. Next type of intracranial bleeding is subarachnoid hemorrhage, and this is bleeding into the space between the arachnoid and the pia mater. Let's look at this CAT scan over here on the right. You can see white areas all in between the portions of the brain, and they are tracking between the lobes of the brain, and that is classic for a subarachnoid hemorrhage. And you should get good at recognizing that CT scan because it's often shown on board exams. This will occur very suddenly, and patients describe the symptoms classically as the worst headache of my life. It's a very severe headache. They can get fever and they can get nuchal rigidity. So the nuchal area is the back of the neck, and it will get rigid from all that inflammation and blood back there. The CT scan is usually diagnostic, but a small portion of patients have a negative CT scan even though they have a subarachnoid hemorrhage. And in these patients, you can detect a yellowing of their CSF on a spinal tap. It's called xanthochromia. Importantly, these patients don't have focal deficits, so even though there's bleeding into the brain, you won't see the motor lesions or the sensory lesions you see with some other types of intracranial bleeding. Almost always, these types of bleeds occur from rupture of a berry aneurysm, and I talk about this in more detail in the module on cerebral aneurysms. The most common site is the anterior circle of Willis at the branch points of the anterior communicating artery. People who have AV malformations in their brain can also get subarachnoid hemorrhage, and there are some conditions associated with subarachnoid hemorrhage and berry aneurysms, including Marfan syndrome, polycystic kidney disease, and Ehlers-Danlos. The last bleeding problem inside the skull that we'll talk about is an hemorrhagic stroke, and that's also called an intraparenchymal bleed. And this is usually when small arteries or arterioles rupture, most commonly from hypertension. It also happens when people are on anticoagulation. It can happen with brain tumors, so a brain tumor can cause bleeding, either by bleeding from the tumor itself or by eating away at a blood vessel. And then sometimes patients have an ischemic stroke, and then the area of the brain gets reperfused and it transforms into a hemorrhagic stroke. So the sites of these hemorrhagic strokes are different from the sites of ischemic strokes. You may recall that the most common location for an ischemic stroke is the middle cerebral artery, which supplies a large area of the cortex. But these hemorrhagic strokes happen most commonly in the putamen, which is part of the basal ganglia. They also happen in the subcortex, the cerebellum, the thalamus, and the pons, and all these areas have types of blood vessels that are vulnerable to rupture. So because the putamen and the basal ganglia is the most common location of these bleeds, you should know what the symptoms are of a hemorrhagic stroke in that region. So look over here on this picture on the right. This is the putamen right up here. But of course right next to it is the internal capsule with motor and sensory fibers, and down here is the thalamus. So strokes in this region tend to not just affect the putamen, but affect all the neighboring regions. So if you have a stroke in this region, you'll get contralateral hemiparesis from damage to the internal capsule. You can get hemisensory loss from damage to the thalamus, so you will see complete sensory loss, face, arms, and legs in people with strokes in this region. And then the frontal eye fields are in the frontal lobe, very close to the putamen, so you can get gaze deviation towards the side of the bleed. That's what happens when you have a frontal eye field lesion. So watch out for patients with hypertension who present with left paralysis and sensory loss but eyes deviated to the right. This is the typical type of syndromes of somebody with a classic putamenal stroke. You should be aware of Charcot-Bouchard aneurysms. These are microaneurysms of very small branches of the lenticulostriate arteries, which are branches off the middle cerebral artery that supply the deep areas of the brain like the basal ganglia and thalamus. And they're believed to be the origin of hypertensive hemorrhagic strokes. So if you see a board question about someone with a hypertensive hemorrhagic stroke and they ask you for the mechanism, you should think that it may be Charcot-Bouchard aneurysm rupture. There is a condition called cerebral amyloid angiopathy where patients get recurrent hemorrhagic strokes. So these patients get beta amyloid deposits in the walls of their arteries of their brain, and that makes the arteries weak and prone to rupture. These patients tend to get recurrent strokes in the lobar region, so like in the frontal lobe or the parietal lobe, and so this is an unusual spot for hemorrhagic stroke. Remember, I told you they're classically in the putamen and the basal ganglia. And these are also usually smaller strokes than the massive lobar strokes you see with middle cerebral artery infarction. So watch for an elderly person with recurrent hemorrhagic strokes. They probably have cerebral amyloid angiopathy. Anytime you see someone with recurrent hemorrhagic strokes, you should think of this condition. The last thing I'll talk about is intraventricular hemorrhage, and this is bleeding into the ventricles of the brain, and this is something that happens to premature babies. So they hemorrhage into the lateral ventricles usually the first couple days after they're born. If it's mild, they can be asymptomatic, but more severe ones can cause them to lose consciousness and have hypotonia. And then if it's an enormous bleed, they can get seizures and have comas. One thing they may ask you about on your boards is obstruction of the foramen of Monro, and this is also called the intraventricular foramen. It's what drains the lateral ventricles into the third ventricle, and the clot can obstruct that, and board examiners like to test your knowledge of anatomy in clinically relevant situations, so this is one of them. So what you would see is a baby who's got enlarged lateral ventricles but a normal third and fourth ventricle because it's the outflow of the lateral ventricles that's obstructed, and you treat this by placing a ventriculoperitoneal shunt, which drains the CSF from the lateral ventricles into the abdomen. The reason babies get this is there's a problem with something called the germinal matrix. This is a highly vascular area that surrounds the ventricles, and premature babies can't autoregulate this area very well, so the blood vessels get large and they can rupture and bleed into the ventricle. In full-term infants, this area has decreased vascularity, so this usually doesn't happen, and that's why it's a premature baby problem. And that concludes our module on intracranial bleeding.